to attendees and participants, to our here eminent speaker. They are with me today. Today, really, I feel proud that I am in between and very eminent speakers, and they are naming the high rank speaker in ROB worldwide. I'm not saying like that because for the sake of this meeting, but really these people, they are the most expert. They are the most people, they are working in ROP and they have experience for a long period of time. And also they are the organizer, most of them, they are in the organizing of the, I think the ROB, worldwide ROB conference. It should be last year here in Dubai, but I think because of Corona, they just postponed. We hope maybe they will think to do it this year. I think Dr. Azad, Dogra, and they are preparing to do this. So really, I feel very proud that's I'm in between these eminent speakers. And we are going to start by the first speaker, Dr. And allow me to introduce Dr. Professor Azad. He's an MBBS, MD ophthalmic, AMS, FRCSD. There's a lot of things that he is a vitreoretinal consultant and director ROB service in Bharati Eye Hospital, New Delhi, India. And he is, I think, the president of ROB conference for this time. Dr. Azad, he is going to give a very nice and introduction for our today. And I have seen this presentation. It's an excellent, it will be amazing. He will give ROB secret that no one will tell your vitrectomy. So can we have Dr. Azad with us? Dr. Azad, you are with me?
He's
Dr.
disconnected.
Azad? Disconnected. Okay. So we will wait for a second or 1 minute, just if Azad can connect again. Or we can have Dr. Hassan first, then we'll have Dr. Azad. It's okay.
I think that's a good idea.
Let us give only 1 minute only. So, because I think what Dr. Azad will tell, it's very important and very nice introduction. Everyone can build on that, I mean, very nicely. I hope he will join us soon. Is there any? John? Not yet?
Not yet, Doc. I'm
Okay.
contacting and calling.
Okay, I think maybe we, as for sake of time, we have maybe to move to the next speakers, Dr. Hassan Hasid. He's going to talk a role of anti-VGF in management of ROP. Dr. Hassan is a vitreoretinal surgeon, consultant ophthalmologist in Dubai Hospital. My dear friend, Dr. Hassan, the mic with you.
Thank you, Dr. Mohammed, for the invitation, and thank you to be with such an international expert in this meeting. And I want to thank Novartis for sponsoring and congratulate them as they got the approval to use the ranibizumab in ROB in Dubai, in UAE, just 2 months back. And for us, this is very important during the practicing. Let me just share the presentation.
Dr. Azad is here. Yeah.
Dr. Azad. Okay, it's up to Dr. Azad. Azad, I introduced you, but you are not there. I'm sorry if you, okay. So I were planning, Doctor. So if you can share, okay. So Dr. Azad came back again, and I hope, can you, already.
Excellent.
Very nice. Yeah, can you share your screen, please?
Shall I start?
Yes, please. Yes, we are waiting for you only.
The internet is low.
Yeah, try to do your best, what we can do.
Yes, yes.
Can you share the screen, please?
Yeah, I'm sharing, you know.
Okay.
Just a moment, just a moment.
Okay.
It's just delay. Don't worry. It's
Okay.
okay.
Delay. Okay. Very nice.
Is it okay now?
Yes.
Perfect.
Okay, just I'll make full screen.
Yes, please.
Correct.
Yes. So, shall I start now?
You have
Yes,
to-
please. Go ahead. Yes.
Yeah, now it will come. Okay. Okay, we are fine. Go ahead.
Okay. So I'm going to talk something, you know. Can you all hear me?
Yes, it's very clear, Dr. Azad. Go ahead.
Can you all hear me?
Yes, Dr. Azad. Go ahead.
Okay. So, first of all, I thank Dr.
John,
Miri for giving me this opportunity webinar. And, I have no financial interest. I am going to talk about the birth weight. There are very simple things, you know, which will
John is the sound is from for me or for everyone.
For Dr. Asad, it's delay.
Yeah, but I cannot hear him.
idea that what is it
Hmm.
1200 grams.
Okay, can you just
You know, and up
Dr.
to,
Azad, can
say,
you hear
800
me?
grams. It is
Dr. Azad, can you hear me? Hello? Dr. Azad.
It's disconnected.
Disconnecting. I think, okay, can you send him a message that to change the place, please? Tell him to change his place. Maybe the connection is difficult and maybe in another room on another place, he will get a very nice, so the sound was interrupted. I think this is only, I know, I received a message from this one only because of internet from Dr. Azad itself. So I think it's better to start with Dr. Hassan. Hassan, if better, if you can go ahead. Yeah, so and when just John, can you contact him and tell him just to change the place?
Yes, I
Okay,
will.
thank you. Okay.
Again, good evening, and we hope that Dr. Azad will have a good internet. Just
Okay.
I will speak about the role of anti-VGF in the ROB's treatment, especially now with this new approval which come through the last 3 years. Generally, when we have a patient with ROB, we discuss with the family about the choices of the treatment, pros and cons, and generally, if we delay the laser from the 33 weeks until the 40 weeks, generally we save the baby from around minus 13 diopter of myopia. And generally,
How, Dr. Hassan, sorry? Can you clarify this point? I didn't get it.
Yes. If we have a baby who has developed the disease generally in the 35, 33 weeks when the disease it will be appear for the baby when the baby enter the phase 2 of the ROB. And if you delay this laser for the 7 weeks, if you give the injection for the baby and delay this laser, you will save the baby from around minus 13. We have in the right side here when baby receive injection and he developed recurrence after 7 weeks, and we did laser for him, he is minus 1.5. On the other hand, the patient here received the laser on the 34 weeks and he has minus 13. So delay the laser by using the injection, it will save the baby from high myopia and will give him the chance to have a full vascularized retina and visual field. And still, according to the statistics and numbers, still the ROB is the first or the principal cause of blindness overall the world, especially in the high-income countries. And if we review the history of the ROB, it's beginning from 1940 when they discovered and they said retrointestinal fibrosis. Then in 1984, the international classification for the ROB come and give us the stage and the number of the clocks and the threshold disease. And in 1987, they enter the surgical stage, the 4 and 5. And in 1988, the cryo-ROB give the treatment as from the cryopexy. And in 2003, the early treatment for the ROB by the laser approved it's better than cryopexy by the visual acuity and anatomical outcome. And according to that 2005, the international classification for the ROB reclassified that and enter something about aggressive posterior ROB and speak about the plus and pre-plus and also about the zone 1. And here in 2004-2007, they discovered the Anti-Vgf for treatment colon cancer, and they entered for treatment for diabetic retinopathy and even the ROB. And in 2011, it was the first randomized control study which published in the England Journal, which approved the bevacizumab as a treatment comparing bilaser in the zone 1 and zone 2 posterior. And after that, the CAROB study, which came by in Germany to compare by 2 doses of ranibizumab and ROB, and also evaluate which missed in the BEAT study about the VEGF level in these preterm treated by the anti-VEGF. And 2019, it was published by the Rainbow study, which compared between 2 doses of ranibizumab and laser, and it was randomized, and it's going in 26 countries, and give us also study the results of the injections and the laser and the re-injection rule, and also give us about the level of the VEGF, which was concerned from the BEAT study. And according to that, as we changing the modality of the treatment, the ICROB, which met just around 5 months back, and they going to review the definition, and they enter something which related for the injection about the regression because of the injection, or spontaneous regression, or regression because of the laser. And also they give the definition of macular notch, and also the pre-plus and the plus. And we wait for the future, the result from the Rainbow study for the 5 years, which we look at the systemic effect of this medication, and also the Firefly and Butterfly, which also randomized control study about the role of aflibercept comparing by laser and treatment of ROB. As we know that the disease is coming because of these babies and then NICUs enter 2 phases. The phase 1, which will be from 22 weeks until 30 weeks, it will be hyperoxia, and here there is the retina will not secrete any VGF. And the baby, when he enters the hypoxia, which will be phase 2, generally will begin from 31 weeks. They will decrease the oxygenation levels, and the baby will enter the need for the VGF, and it will be the ischemic. There will be secretion of a lot of VEGF, and it will be a threat of the VEGF, and here the disease will happen, and it will be the screening generally begin in this time, generally from 31 weeks. And here is the relation between the phases and the stage of the ROB. Generally, the goals of the treatment of the ROB is best visual acuity and best anatomical outcome and less side effect. And if you go back to the BEAT study, which will discuss that, you can see that in the phase 1, the baby here is just away from anything. When he enters the phase 2, generally the aggressive posterior will become, or the stage 1 or stage 2, and the role of the treatment will be around this area. Which we learned from the BEAT study is that the bevacizumab has a role in the treatment of ROB in zone 1, stage 3. But about the the recurrence of this, the recurrences here, disease just studied for just around 54 weeks. And the primary outcome was changed after collecting the data, and also just was a recurrence of neovascularization in one or of these eyes and require retreatment, just not recurrence. It required retreatment. And it approved that the laser is, the injection is better than laser in the zone 1, but there's not superior in the zone 2 posterior. And here is also the definition of zone 2 posterior came for us. It wasn't before there. And as this the bevacizumab was using the half dose, which we use it for adult, and there is clear evidence that this VGF is suppress the VGF in the serum of the babies and the adults. And you can see in the right side here that the bevacizumab suppress the VGF and the serum. It's even extended for sometimes for 12 weeks. And this is sometimes not sometimes, here's the principal stone that these babies, they need the VGF and other organs like the brain or lungs or kidneys. And here is the worries and concerns come about them using this medication with this dose. And here is the reports came in 2017 from American Academy about that there is some concern about the neurodevelopmental effect of these anti-VGF used in these children in this dose. And there is some even evidence that there is this baby who treated by the ROB and comparing by the baby who's treated just by laser and the cryo, they found they have a neurodevelopmental impairment and cognitive impairment. And the best review for these data systemic data approve that there is some impairment from the neuro part of these babies. For that, then the CAROB study, which come in Germany, discussed the 2 doses and also evaluate the VGF level in these children and these baby infants. And it was randomized, and they enter just not zone 1, they enter all the type 1 ROB treatment. And you can see here the VGF, the level of the VGF was during the study wasn't affected as in when we use the bevacizumab, ranibizumab didn't affect it so much, and most it will be the same. And which we learned from the CAROB study, it was give us that there are 2 doses, the 0.1 and 0.2 is effective in treatment of ROB, but wasn't clinically significant. But on the other side, and here it's approved that the physiological intraretinal vascularization in the lower dose was better than higher dose, in spite of this is very important for us that using a lower dose, maybe it will be better for the vascularization, in spite of you endanger the baby to have a recurrence earlier. Another thing is the VGF plasma level wasn't systemically altered in either groups. And it was a pilot study. Here the rainbow study was built. It was randomized and comparing by the 2 doses with laser. And it took all the zone, enter the zone 2 as a stage 3 as when we use it for laser and type 1. And according to for this study, which already have recruited around 230 babies in different countries, and also here they enter another modality is the re-injection for these babies. And according to that, you can find that there's around 30% in the patient who receive the ranibizumab need re-injection or retreatment, additional treatment, and in the 0.1, and also in the laser around 19 of them they need retreatment. And the result of this rainbow study, it was for us more logic, because they use multiple endpoints. The first, the baby should be survive until the primary endpoint, no active ROB at the primary endpoint, no treatment except the study treatment, no favorable strategical outcome. And here you can find that the baby who received the 0.2 ranibizumab has around 80% treatment success, comparing by the laser 66 and by the ranibizumab 0.1 around 75. And the most important thing, the unfavorable structural outcome was 1 in the ranibizumab and 7 in the laser group. And about the interpretation for this study, which was the p-value should be less than 0.05, but in this study was 0.05, which considered ranibizumab might be superior to the laser therapy. And if about the VEGF level, you can compare between the babies who received the ranibizumab 0.2 or 0.1 and the laser, it's around the same. For that, the ranibizumab got the approval in Europe to be the first treatment for the ROP in zone 1 and zone 1, stage 1 and stage 2 with plus, so stage 3 and stage 3 with plus, and in zone 2, stage 3 plus, and aggressive posterior ROP. And the Rainbow study also make extension for 5 years to see the long-term safety profile for this medication on the baby neurodevelopmental. About the modulating the dose, which it looked like that now, especially in the pediatric eye disease investigator group, going to escalating the dose of bevacizumab, they reach around around 30 microgram of bevacizumab can give the effect of 100% of cure of from ROB for 4 weeks. And here is for us, it will be for us the decision decreasing the dose for the treatment of the ROB give us first the chance for have normal physiological vascularization for the retina and decrease the danger for the baby to be exposure for this anti-VGF, which will affect the other organs. And I will speak about our just retrospective data which we collected in our
Hassan,
hospitals.
we have 1 minute or
Yes.
please.
Just here we review the data and that we study the recurrence of ROB in zone 1 after the intravitreal injection, and we study the prolonged oxygenation as a risk factor. And we found that really if the baby was can't wean off from the oxygenation, he has a risk factor to have a recurrence. So through that, to conclude that according to all these studies, all the anti-VEGF has a rule in the ROB. Ranibizumab is the first anti-VEGF approved for the ROB in the Europe and especially here now in the UAE. The ongoing research, it will give us an idea about the long-term safety of this anti-VEGF in infants, the ideal dose, and the type of the anti-VEGF which we should supposed to be used, and about the reactivation rate in the ROB after the anti-VEGF. And in the end, prevention of this disease by controlling the the supplementary oxygen therapy. Thank you very much. Thank you, Dr. Mohammed.
Thank you very much, Hassan. Excellent presentation and comparison. I think we can go now directly, then we will have discussions at the end for all the talks. If anyone have anything, just keep in your mind, or you can just put your question about Dr. Hassan from the panelists here. And also for our dear participant, if anyone have any question, can send a question through and question and answer. We will give this answer, and question will expose to the main, and you can send it by the name if you want to specialize answer from a certain speaker. And if someone have, experience and he want to share with us his experience, he can raise hand and we will give him a chance to talk and to discuss with our panelists and speakers. Now we will go directly to our second speaker, Dr. Azad. I hope now the connection is good. Dr. Azad. Dr. Azad, you are hearing me? You are mute. If you unmute yourself.
Yes, can you hear me now?
Yes, we can hear you. Okay, we hope,
Yes.
inshallah, that time it will be okay. Okay, can you share screen and start?
Yes, I'll go back where I left. Yes. I think we were here.
Yes.
I was talking about the birth weight. And as I mentioned, if the child is more than 2000 grams, it is highly unlikely that the child will develop retinopathy of prematurity. If it is greater than 1600 and up to the 2000, it is less likely that the child will develop retinopathy of prematurity. And if it is more than 1200, between 1600 and 1200, it is likely that the child will develop retinopathy of prematurity. And if it is between 800 to 1200 grams, it is likely. And if it is between 800 to less than 800 grams, it is highly likely that the child will develop retinopathy of prematurity. And this is the risk factor score, which is, I have devised this score. If it is, equal to or more than 1600 grams, the risk factor is 0. If it is less than 1600 grams to 1200 grams, the risk factor is 1. If it is less than 1200 to 800 grams, the risk factor is 2. And if it is less than 800 grams, risk factor is 2. Then coming on to the gestational age, if we take into consideration the gestational age and the probability of developing retinopathy of prematurity, if it is greater than 36 weeks, it is unlikely to develop retinopathy of prematurity. If it is more than 32 weeks, it is less likely. If it is more than 28 weeks, it is likely that the child will develop retinopathy of prematurity. And if it is less than 28 weeks, it is highly likely that the child will develop retinopathy of prematurity. These are very basic things which I am telling here. And this is the risk factor score which I have devised. If it is greater than 36 weeks, the score is 0. If it is 36 to 32 weeks, the score is 1. If it is 30 to 38 weeks, it is 2. And if it is less than 28 weeks, it is 3, which means it is highly likely. If we combine the two, and you can see here as we go, the risk factors for 1 and 2 means birth weight and gestational age is 1 and 2. And if it is 2 and 3, it is 2 and 3 risk factor. 2 and from 0 to 3 is the, it is in terms of development predictability of the retinopathy of prematurity. Now we have to see what are the critical periods in the screening. This is very important and very basic thing. If the child is, born 28 weeks, less than 28 weeks plus 800 grams, the screening should be done between 2 to 4 weeks. This is very important. And if the child is, a child is born more than 28 weeks and more than 800 grams, it should be screened, at first screening should be done at 4 weeks. Now, what is the second screening? Second screening is very important because this is the time when the child develops retinopathy of prematurity. This is a very critical period. And in this period, it is, as we have seen here, if the child is between 26 to 30 weeks, the retinopathy of prematurity must be screened between 30 to 34 weeks. If the child is born more than 30 weeks, then the child will develop retinopathy of prematurity between 34 to 40 weeks. And all treatable ROP happen during this time, these two periods. And 40 to 45 weeks, if we want to say that this child is free from retinopathy of prematurity, we can say that if the child has been screened up to 40 to 45 weeks post gestational period. And this is the time when we also say that the child has got regressed ROP if it is more than 45 weeks post gestational age, and if it is and also for both spontaneously and treated retinopathy of prematurity. These are the critical period in the development. Now, how to grade the vascularization? This is very important, very basic thing I am talking about. If the vascularization, this is the normal vasculogenesis. If the vascularization has reached, say, up to zone 1, we call it immature 1. Often the residents, they find it difficult when they want to, classify the normal vasculogenesis. So this is immature 1. Vascularization is up to zone 2. If you see here, the vascularization has gone mostly up to the zone 2, zone 2, from zone 1 to zone 2, and therefore it is called immature 2. And when the vascularization, as you can see here, has gone almost going up to the ora serrata, which means up to zone 3, it is immature 3. So this is how we, label the normal vasculogenesis, and this is zone, immature 3 is complete vascularization. Now coming on to plus disease, see, these are the two important factors in the development of retinopathy of prematurity. One is the plus disease, and the other one is the, the zones, which are very important. Now the plus disease is, the development of, it is a result of the hypoxia. When it is in the periphery, it, develops into, the ridge and other, things I will show you just now, the vascularization. And when it is on the hypoxia increases, it comes from the periphery, comes on to the posterior pole. When it comes to the posterior pole and it develops tortuosity of the vessels, then it is called plus disease. Basically, it is the severity of the ischemia which is traveling from the periphery onto the posterior pole. And when plus disease is there, it denotes severe hypoxia, and it begins from the temporal retina, as I told you, and it reaches up to the posterior pole. And plus disease is a severe form of hypoxia. Now this is a mild plus, this is a moderate plus, and this is a severe plus, which we can see here. So this is how, you can see this thing, And now we come on to the stage. This is the stage. This is just a small ridge. This is stage 1. This is stage 2. You can see the ridge has become thickened. And this is stage 3, where you can see the ridge is now lifted little bit, and the vascularization have, gone onto the ridge. And this is stage 4. You can see the ridge is there, which has thickened not only, and there is a pull on the ridge also. And then this is stage 5. In stage 5, different types are there. The one on the lowest, on the right side and below is the closed funnel, and the one on the left side, and it is on the above, this is the open funnel. If there is an open funnel, this is the sign where, you can where you can try your hands for the surgery. Now, if we have plus disease and the zone, and we want to predict the disease, about the disease, if it is a severe plus and it is zone 1 and 2, this child will definitely develop a blinding ROP, and therefore here the anti-VEGF treatment will help. Now coming on to, simple plus disease, not severe plus disease, and if it is in zone 1 or 2 or 3, and if it is stage 2 and 3, the laser will be something, which is very good for this baby. And then if it is a simple plus, not a severe plus, and zone 1, 2, 3, but stage is 4. If the stage 4 has reached, this child will definitely need a surgery, and maybe along with that, a laser also. Now, the other thing is, how do we say that this ROP has regressed? What are the signs of regression? And if it has been treated by the laser, these are the signs. One is in the periphery of the retina, and there the next is the center of the retina. What we see is there is a decrease in the height of the ridge, disappearance of the ridge, and disappearance of the vascular network, which is gone onto the ridge, and there is a revascularization of avascular area. Many a times we find that after the laser, the revascularization is now going beyond the area of the retinopathy of prematurity, or beyond the ridge. And coming on the center, there is a decrease and disappearance of the plus and absence of angry red appearance. So these are the signs of regression when you treat with the laser. Now, what are the signs of regression when it is treated with anti-VEGF? One is, number one, very important, is the clearance of the media. The media will clear. The second thing is the recanalization of the closed vessels. The third is the advancing neovascularization from zone 1 to zone 0 to 1, 1 to 2, and 2 to 3. And the Next is the decrease and disappearance of retinal hemorrhage. And then there is a decrease in the plus disease. And last but not the least is the disappearance of the angry red color of toxicity of the vessels at the posterior pole. These are the signs of regression, which is not mentioned anywhere in any book. So that I thought that this is from my personal experience, and this should be listed here so that a person, who is going to see the signs of regression, he is aware and he looks for these signs. Now, this is very common. You find refractive error in the child who had earlier retinopathy or prematurity, either spontaneously regressed or laser treated or anti-Vgf treated. And many of these cases, the visual acuity is not normal. And this is basically not only due to laser, but basically because of the prematurity. Only thing is, when you do the laser, it is maybe a little bit higher. And if it is spontaneously regressed, the myopia will be less. So this is all I want to say in this presentation. And as I always say, the ROP is the grandmaster, and the one person who is treating, he has to play his game, very cautiously, because you don't know what the ROP is and which course it will take. So therefore, it is very unpredictable. But the signs and the other things which I have said, you can definitely predict the type of ROP and the severity of ROP. And that's why I thought that this should be useful. Last but not the least, a wise man can learn more from a foolish question than a fool can learn from a wise answer. And thank you very much for giving me this opportunity. I'm sorry because of the intermittent internet connection, but then thank you so much.
Thank you very much, Dr. Azad, for an excellent presentation and very, very new and also information that we will learn from you. Actually, this one, maybe you can just, if you allow us to have this presentation and also to to give to all other people so they can learn a lot from this information.
Yes.
Thanks a lot.
Yes.
And we will have a discussion. I'm sure there will be a question from Dr. Haya, Dr. other colleagues here, Dr. Susanna and others, but it will be at the end of the session. And thanks for, you changed the place. I think that now the internet is nice and we can hear you very nicely, smoothly. So we will move now to the third hour guest speaker, also Dr. Susanna Teixeira. And Dr. Susanna is a professor of vitreoretinal surgeon. And sorry, and she's an ophthalmology department, working in ophthalmology departments. This called Cruz Vermelha, Portuguese Hospital, Lisbona, Portugal. Dr. Susanna, you are with us? Hello.
Just 1 second. There's
now
also
I'm
delay.
mute. Yes, I was not able to share my screen while the other screen was being shared. So I think now I can
Susanna, she is going to talk about the role of she will talk about angiography in ROP, findings before and after treatment, and there will be about the relapse patterns.
Well, thank you for this opportunity to present my humble experience with angiography and for the invitation this meeting. So, well, the name, it's fluorescein a new dimension, because we know that our life of dealing with ROP is based in indirect ophthalmoscopy. That's what we do every day, seeing the babies with indirect ophthalmoscopy. Then when it came our RedCam optos, those wide angle machines, it was a very interesting image, but it's not a three-dimension image. But when I saw the first angiography of the baby, it was a new world that I could see. I mean, it's difficult to know. I can see that the vessels here cross, but when I do the angiography, I can see what's happening inside the eye with just an accuracy, with such a good view that it's very, very, very nice to do. And it was a new world that was opening in front of my eyes to have this detail and to understand what's happening inside the eye of the baby. So of course, here I can say by this image that we have a 3 disease, a stage 3 disease, but when you perform the angiography, you see the stage 3, you see the leakage, so the violence of the disease, you can see what's happening behind in the vascular, and so there is a lot of information inside this exam that it's not just in the indirect ophthalmoscopy. So you can see the extent, and really you can see the stage 3, but here you can see the stage, are completely sure what kind of stage you can see. You can see the dropout of the capillaries in the early times of angiography. So you can see the violence of this disease, and you can see the leakage posteriorly. You can see the extent of the stage 3 and the stage 2. So you can see nicely which stage you have, and you can say nicely which kind of ROP is inside of your. Also, the anterior in those babies that have a more aggressive ROP, you can see also leakage of fluorescein in the anterior segment. So the first time I did the angiography that was opening to us ophthalmologists, and those that have the chance, this machine and to make the angiography, they are very lucky, like I have from the last 4 years now. So you can see with detail the capillaries, the great vessels, the shunts, the alterations with a lot of detail. Also, in the babies that are already treated, you can know if there is some activity in the disease. For instance, I see this hemorrhage, and I don't know if this hemorrhage is some kind of new disease or if just the old disease going away. So I do the angiography, and I can see there is no kind of. So this hemorrhage is just disappearing of the disease that there was anteriorly. Even in the babies that I did vitrectomy, I used to make the fluorescein angiography to be sure that there is no activity in this eye. So you can see here, there is a fibrovascular still here, but you can see there is no activity, just a little
It's a delay, just kindly wait.
leakage of
Dr. Susanna?
It's delayed, doc. Just kindly wait.
I think there is a problem worldwide of internet
okay,
today.
now you can hear me?
Yes.
Yeah.
Now
yes,
you can hear me again? We have the same problem.
Yes.
Can you hear me now?
Yes. Okay, go ahead. Yes, okay, please.
I'm sorry. I had such a wonderful internet. And so I was speaking about the benefits of the angiography, and now I'm going to speak about the findings of angiography in the babies that we inject with Anti-Vgf. And there is a lot of papers about this subject. And it's very interesting because I was looking already for these alterations in the vascularization of the peripheral retina before I had an angiography. I had the possibility to do angiography. I already saw the vascular tortuosity and all that. Can you hear me? Oh my God. So we can see.
We can hear you nicely.
Can you hear me again?
Yes, you are very
okay. So the first thing we can realize in a baby that had ROP, and we made one ROP and we made the injection and everything goes away. If you do the angiography, the first thing you can see is a pachychoroidal filling, not a lobule that we are used with the other kids and grown-up people, but a pachychoroidal filling that also in the choroidal will have impact of the disease and perhaps of the anti-VEGF. We never know. Before I had the angiography, I could see the impact of the anti-Vgf. So I could see the tortuosity, I could see the shunts, the anomalous branching of the peripheral vessels. As you can see here, a circumferential vessel in a quiet eye. So I injected, I had a type 1 ROP, then I injected, everything goes away, but really you have this kind of alterations in the peripheral retina. But when you do the angiography, you can really see all the extension of this. So there is no active disease, but you can see those shunts that really are not artery vein, but they are vein, which is very interesting. And they cross the medial raphe, so that's not usual at all. And you can see that abnormal branching the periphery. Also, you can see in the early times of the angiography, you can see in the babies that had aggressive posterior ROP, they frequently have this pattern of dropout capillaries in the periphery, and you can have these cut vessels in the transition for the avascular retina. So you have scalloped limits the avascular retina, you have pruning of those vessels, so they are really cut, but they don't have fluorescence, I mean, they don't have activity, and that's very interesting. Sometimes, and that's more rare, you can have these tangled, very disorganized vessels in the transition, like a tangle, but in the angiography, you can see they have no leakage. So they are competent vessels, but organ in a different way with huge avascular retinas. So no relapse disease, but you have these alterations in the vessels of the see here again. In other times, you have double blunt vascular patterns. So this is normal patterns, but sometimes it's here where we can have relapse disease. Most interestingly is that even in babies that were not injected with anti-VEGF, we can also see some kind of the peripheral vascularizations. What do I mean? Even this is the eye of a baby that I injected with not aggressive posterior, but zone 1 posterior ROP. This is the eye injected, and it has all the images I told you before. But when I saw the other eye that I didn't inject, but had type 2, I mean, it had ROP that disappeared, regressed spontaneously, we also in this eye can see some kind of anomalies with a vascular retinal eye and with those looping and shunts in the periphery. So there is a world wild that we have yet to know about ROP treated with anti-VEGF, and so that fluorescein angiography show us. Our problem, more than all this, is the avascular retinal peripheral retina. Are they precursor of relapse disease? So shall we treat all these avascular retinas? Before I had angiography, the possibility to make angiography, I already followed up those avascular retinas for long years. So this is a baby injected 11 years ago and still has, as you can see, huge avascular retina, huge avascular retina with no relapse disease. And I think we have two kinds of avascular retinas, those that are the quiet to me. So when I have the baby with 6 weeks postmenstrual age with still an avascular area, I perform angiography. If I see no leakage in the periphery, as we can see here, of course, I've got some alterations of the vascularity, but I've got no leakage in the periphery or just a little mild diffusion leakage in the periphery. I just follow those eyes. I don't make anything, just perhaps it's the normal way of vascularizing the periphery in these cases. But sometimes we can see a little leakage in the periphery that can tell us that perhaps the disease, or somehow there is some VEGF there that still has some kind of activity linked perhaps with VEGF because there is leakage from the vessels. And we can see here more clearly that you have apparent vessels, but you have leakage in this marriage, in the last vessels before the area. So I tended to make laser because I'm a bit afraid that I have a recurrent disease. That's what you don't want. So I did, and I do laser sometimes if I cannot follow those babies. What is interesting is even with laser and the vascular area completely, you still can see this mild leakage on the transition where there was before in the angiography the initial leakage. So of course, I think we may prevent the relapse disease, but we cannot completely be quiet, be comfortable, because even after the laser, we have some kind of activity in the periphery. So there's a huge world to know, and we still have a lot of things to learn. This is the baby injected 11 years ago that has a huge, as you can see here, the nasal, a huge vascular periphery. And I've got this that I see in direct ophthalmoscopy, but I called it neovasals, like we have also in the retinopathy of the diabetic retinopathy. So since I make angiographies from 5 years now, I found this in this baby. Has a huge vascular area and these occult neovasals that defund a little bit, but there is no relapse disease in this baby. And this kind of findings are also found by other colleagues, normally in this paper. So I again say, we've got a lot of things to still about ROP. Shall we laser all these retinas? Perhaps we are lasering too much. Which retinas shall we laser to prevent what we want to prevent, that is the recurrence disease? And we know that we have failures in this treatment, we have recurrences, and we must always diagnose this and treat these failures and these recurrences. Me and other colleagues call failure when I inject, and still the next week I will have a worse of the disease. So the disease is not effect. And I have recurrence when the disease disappears after the first injection, but then I've got again plus disease and some kind of reappearance of neovascularization, whatever is this neovascularization needs, the format of the neovascularization. And it's very important in this case is to perform, if possible, an angiography to know why do I have this recurrence? Because most of the times I've got recurrence or failure of the treatment because it was not well diagnosed, the disease, and we have different diseases. So now about the patterns of the disease of the recurrence. The patterns of the recurrence are basically two patterns. The first one, this is a baby injected, recurrent, again, plus disease. And there is one pattern of recurrence, the recurrence at the advancing edge. I did laser in this case. The other eye, also a recurrence in the advanced edge, and I did again laser. And there's a second pattern of recurrence that is the recurrence, always plus disease, but the recurrence at the advancing edge and at the first site ROP. So there's the two patterns of recurrence that we can have and are very nicely diagnosed with angiography. You can see the leakage on the first site and the recurrence in the second in the advancing edge. We must always recognize these patterns, and when we find a recurrent disease, we must treat this recurrent disease. Sometimes the recurrent diseases are not real ROP, are some kind of influence of other diseases that are also vascular diseases of the retina of the premature and other of the babies that can alter the course of ROP and usually present as very aggressive ROPs. And I'm speaking about new entities that people trying to give new names that are the mixed between fever, basically, and retinopathy of prematurity. So there are some descriptions of what that I think is somehow a preterm exudative retinopathy, vitreous retinopathy. So there are descriptions in papers about this kind of presentation, some like aggressive forms of aggressive posterior ROP. Can you hear me?
Yes, we can hear you. Yes, yes.
Sorry.
Yes,
So
okay.
there is another description, mainly in India and in Mexico, that is a form of a presentation of ROP that is very similar to oxygen-induced retinopathy. So it's secondary. The babies are big babies, and the capillaries
We can't hear you now, Dr. Susanna. If you can hear us.
I think the whole connection is lost.
No, I can hear
delay.
you.
It's delay.
She can hear. Okay, okay.
I
Can you just can you just little bit 30 seconds go back, because that time we didn't hear. Okay.
Oh, so I was telling about typical phenotypic presentations of ROP. Could you hear me about that?
Yeah.
So the influence of some kind of genetic diseases like exudative familiar vitreoretinal exudative fever, the link between fever and oxygen-induced retinopathy. So fever can make, if linked with ROP, can make a different presentation of ROP that some colleagues, Ropi or aggressive posterior vitreous retinopathy, that you could see, hear this before. Can you hear this?
We hear it. Yes, yes, yes.
Yes. So, and you hear about oxygen-induced retinopathy that is very frequent in India and in Mexico.
Yeah.
So these are different forms of retinopathy that also have different treatments in which angiography help us in the treatment. So oxygen-induced retinopathy is very important because it's linked with the bad use and excessive use of oxygen during the first days of life. And if you control the oxygen, you don't, even with injection, with the laser, with whatever, not control this disease. So a long time ago, so 10 years ago, I had this baby that it was a cold case of mine. I mean, it's a case I still could not understand, so I put it by my side. And whenever I think about it, I knew something new, I go there. So it was like an oxygen-induced retinopathy because I just around the optic nerve, the optic disc, and the baby is a huge baby. It was the only baby that I had 2 relapse diseases, so I had to make 2 injections. And finally, at 1.5 years, it has the retina connect to the optic discs, so it behaved like a fever. So I think this baby, what he had was an aggressive posterior, so something like a ROP and a fever. Also, 6 months ago, I received a baby. I was referred a baby with some different, what they call different, and really I think it was also a fever, but a fever in a baby. So in this eye, I didn't inject, I went rather to laser. And in the other eye, you see, really, this is a fever. So I also did laser and had a drugged nasal retina, so the fovea is okay. There is a very interesting paper of a friend of ours that asked it to ROP, everybody knows, Maria Martinez Castellanos, that make link together all this information from oxygen ROP, all the information, and try to propose an algorithm for the diagnosis and treatment of babies with retinopathy of prematurity that I think it's a good work of a paper to work this out. I think we should all gather together our information and try to complete, to make a perfection of this algorithm. It's very interesting, and I don't have time to explain the algorithm, so I advise you to read this one. So I'm waiting also for a study from China that will tell us in a prospective way which are the best way to treat those avascular retinas in order to avoid the relapse disease. And finally, I don't really like, I like to use the machine, but I don't like to give them my information. But the images from angiography in retinopathy of prematurity, they are very well used. They can be quite used by these convolutional neural networks to make algorithms in the diagnosis of retinopathy of prematurity. So this is what I have to say about a little bit about everything in angiography in ROP. And I hope somehow I enlightened a little bit, because angiography in ROP, I think it's a world. And in ROP, we have a lot of things still to know and to.
Your voice is interrupted. Yeah, now again. I think this is the last, slide for Dr. Susanna. And okay, that we hear all the, at least presentation. I think we can just stop share from your side, John. And we will move to the next speakers, and we will have also Dr. Susanna with discussion at the end. The next speaker, it will be my dear friends, Dr. Mangata Dogra, and he is going to talk about role of laser in anti-VGF era in ROP. Dr. Mangata, he is a professor, Department of Ophthalmology, Advanced Eye Center, Bigmer, Chandigarh, India. And he is a well-known vitreoretinal surgeon and one of the when also treating ROP. Thank you, Dr. Susanna. Just we miss only in the last. We'll miss you. We miss your voice. Okay, Dr. Mangata, you can go ahead.
Okay.
I think you will not have a problem of internet.
You can hear me?
Yes, very well.
Yes, yes. Well, at the outset, I would like to thank Dr. Emery here for inviting me. And
pleasure and honor.
And it is my pleasure to be part of this prestigious meeting where all the famous people I can see here, they are here. And I'm going to talk about something which we have been using for a very long time. That is the role of laser in ROP, especially in this era where we have heard a lot from two speakers about the anti-VEGF. That's where we are entering. Of course, the current treatments, I'm not going to go into the details here. I'll straight away.
Your slides.
Yeah, please, can you show the slide? Yeah, you are not yet.
You're not seeing my slides?
No. I thought you are already just introducing it, but if you are, you didn't share the screen.
Let me.
Just go share the screen again.
I'll just, let me come back in.
Okay, very good.
Are you seeing
yes.
now?
Yes, but just make it in a slideshow. Yeah, now it's okay.
Sorry.
Go ahead, please.
Sorry. Is it okay now?
Yeah. Excellent.
So I think I was here about the current treatments. I think we already talked about the anti-VEGF. I'm going to talk about the peripheral laser ablation, and of course other things I think were mentioned in passing. And I think I have put different colors here. We are going to have, we already have change in indications for type 1. We were all lasering for quite some time. And now we don't know, we're going to have different indications. Already the zone 1 ROP, most of the people, they are injecting, and so is aggressive posterior ROP. And so I think our indications are definitely changing. And of course, laser is a good treatment, as you see here, and was shown earlier, that you would see in about 90% we used to attain favorable outcome. And all signs were shown very nicely by Professor Azad, that how the plus disease, the vessels straighten up and the disease would just disappear. And I'm just going to also mention, which was very important during the COVID time, many people were lasering either through a box or inside the incubator. This we had published way back, and Anand is here with me, Anand Vinekar, when he was with me in Chandigarh here, because he trained with me those days. And I think this came handy, because I think there was a problem otherwise, and we were scared that we may not infect the baby, or there could be other reasons. So I think this helped us. And I would also like to say that at this time, especially in country like India and many developing countries, I think it is the 532 lasers, green laser, the same laser which we are using for multiple things. We are using it for diabetic retinopathy, for retinal breaks, for vascular occlusions, others. The same laser can be used very safely. And this we have shown right from 2010 and subsequently even 2019. And there are some publication also from, I think, Mexico, where they have shown that 532 laser works equally well. And this is one such I treated where you can see very good effect of 532 and the same laser. Even the problem for us is about the APROP. Now, in APROP, we published way back in Retina in 2009, and we had a 71% had a favorable outcome, and rest, they were unfavorable. And that was the time, was a transition zone for anti-VEGF. They had not really come into ROP. I think that started, of course, we all know from 2011 with BEAT ROP study. And this is the chart we had put in that paper. And you can see even in places like, you see, these were from various places, including Chile here, they had 45, 40%. I mean, that kind of unfavorable outcome, or in cases of zone 1 ROP or APROP. So that is where the whole problem was. And so we also wanted to look at which are the risk factors in APROP leading to unfavorable outcome after laser. I think we did publish this in American Journal 2013. It was posterior zone 1 ROP, which is called also zone half ROP these days, that which, in fact, I'll show you a publication subsequently, or you have a pre-existing or a neofibrobascular proliferation. I'll show you this case also, that these are the cases, they go into unfavorable outcome once we only laser. This was the paper. In fact, this is the only paper till now on posterior zone 1 or zone half exclusive paper in Canadian Journal. What was important and what we were looking at, you can see here 78.6% had unfavorable outcome with laser, only laser, because these were the cases when we were trying to collect from 2006 to 2015. We had not really gone as yet into anti-VEGF injections. And so you can see almost 79% have an unfavorable outcome. So I'm showing one such case of a posterior zone 1 or a zone half. Here the vessel will not even reach the fovea. And you may have something like this very close to the optic disc nasally. And this was lasered, and you can see what happens despite laser, the whole retina, there was a proliferation, and even the stretch breaks happened. Once we have stretch breaks, we have a problem. Even if we want to perform a surgery in such a case, most of the time we are not going to succeed, because here everything is so different. We know as surgeons that how difficult it is once the breaks develops there. So there are difficult situations. If we have a lot of these vessels, new vessels or tunica vessels, TVL, which we call, and I already mentioned about this situation, and another one where we have a lot of proliferation, media haze. So what do? We have a problem. I think I'm going to share one case. Now, if I ask you to raise hand, who's going to inject anti-VEGF here? Probably none. Because look at the proliferation. Nobody would. It will crunch up. It will just. So what do? I think you look at the nasal also. I mean, this is extreme. So what we did, we never wanted to inject. So we lasered this one. But in 2 weeks' time, what has happened? Just look, just in 1 week time, you can see it was lasered adequately. The whole retina is trying to fold and it is trying to contract. And what happened down the line? This is what happened. And you can see this is just in 2 weeks. Now, again, now you're going to inject here. Look at the vessels, how angry looking they are. No, we can't inject here also. Perhaps if it goes to crunch, we lose everything. Anyway, I went ahead with the lens sparing vitrectomy, just try to remove that central sheet there without touching anything else. But you can see it works very well. I think it went back, and I'll show you the final what happened. Not only that, look, even that temporal retina, which was lifted up, has gone back. So I think we can't have one treatment. I think laser was required here, which in fact helped us. Anti-VEGF were not possible in such a situation. I'm sure you can discuss this if anybody would have injected here anti-VEGF. But then we need so many things to be done along with laser, even in this era, which we call as the anti-VEGF era. So most of us would at this time probably inject for zone 1 and Aprp because we know they are less responsive to the laser. And then some of the diseases which may progress despite your laser, there also you may need, I think Susanna has shown some cases like that. And of course, anti-VEGF injection may be followed by a less extensive laser. That is what is important, and that is what is something which we want, especially in zone 1 ROP. We don't want to destroy that much retina. So we all know that laser is very good treatment. You do it once. I think once we are done with it, we are done forever. It's not like a anti-VEGF. You keep on following. You don't know when the recurrence would happen. So those are the issues which are different, and we face such challenges. And of course, there may not be need for that kind of frequent follow-up. In fact, after the laser, ROP regressed after laser, and it regressed nicely, we would not call before 6 months. That is what we used to follow. But no, you can't follow this in with anti-VEGF. So, and I always feel, I have always projected this, the chances of late retinal detachments are negligible with the lasered eye because you have lasered it up to ora serrata. I feel very strongly. Maybe we'll have a lot of retinal detachments happening after anti-VEGF down the line once they'll grow up because their periphery is not lasered. They're going to develop some changes there. I don't know. This is just my presumption. So, of course, there are a lot of concerns still about the follow-up, the late recurrences, how long to follow up. And of course, our systemic adverse events, I think we are not seeing that much. So we're getting more bolder. So I think this is already presented. And I think as far as anti-VEGFs are concerned, all over the world, they are getting more and more accepted. I think reason being already Rainbow trial was presented here, as well as we have now this Cochrane database where they have analyzed many studies that I think at this time, of course, there are people talking in terms of that ranibizumab cases, they show more recurrence as compared to bevacizumab, but then there are so many other things, so we don't know that part. And of course, after anti-VEGF, whatever we do, we are not still sure, what I talked earlier also about the late recurrences and other things. And of course, people are very happy. They are injecting left and right because it's a simple procedure. For laser, you needed to be trained, well-trained. So that is not there. And it is a rapid response. As already said, you preserve visual field as well as less myopia and better visual acuity. I think it was, there is no doubt about that because we laser much less retina. I think combination treatment is the way to go. Still, I think many of these cases, especially zone half, as I showed you, APROP or zone 1, they'll still probably need, in addition, laser and some of them even surgery along with anti-VEGF. And posterior zone 1 definitely requires combined therapy. I think that is something, a challenge still which we are facing. And of course, there are other things which I have already talked earlier. I'll show you one such case here. Just there was in one eye vitreous hemorrhage. We could not have done anything to this eye, but after injection, you can see we could get very good result. We even lasered subsequently. And so I think these are some of the, there's also a publication from, this is from Zhao's, Zhao's group where they have lasered in such eyes. And of course, there are a lot of recent publication where they have shown favorable outcome in treatment of aggressive posterior ROP. This is in the European Journal recently published, where I think what we do these days, I think Susanna has shown nicely that we keep on waiting till the time the vessels are progressing. But if there is a recurrence or the plus disease comes back, or these vessels, they are trying to form again those vessels which we call new vessels, or of course, if we can perform angiography, nothing like that, I think then definitely we need, but we laser much less retina. I think this has been nicely shown. We used to laser everything till this place. And now we wait and let the vessel go, and that's how we laser. And of course, we have also some different experience. This case I show because this was an aggressive posterior ROP, and we injected sphere TVL, and after injection, we lasered. I think we lasered fairly well. But what happens? Down the line, in 4 months, it suddenly detaches, despite anti-VEGF and laser. I think we never used to see these kind of things only with laser. So I think we still have to learn a lot. And so we will be seeing more and more of such kind of cases also where we don't understand. Otherwise, if something regressed like this with only laser, it will never come back. But it does come back in a combined treatment. So I can go on and on, but I would say here that most used these days deferred laser after initial anti-VEGFs has been given in aggressive posterior ROP and zone 1 ROP, due to the rapid response which we see with the anti-VEGF. And deferred, I said, you would only laser, and nicely shown earlier also by Suzanne, if we are seeing recurrence of plus disease or other signs which she has enumerated. And we're going to have definitely newer indication of lasers in ROP, and they are absolutely going to change. So no more type 1 ROP indication is laser. So I think that is what is going to happen. And anti-VEGF injection is mostly followed, if at all, by less extensive laser. So we preserve more visual field, less myopia, as well as perhaps we may be able to control whatever the recurrences would be in future. Although I have shown one case contrary to this. And of course, I already said that we preserve more healthy retina and better visual acuity, less refractive error. So that's the way we go on. So thank you very much, friends, for
Thank you very much, Dr. Dografar. A very nice and excellent presentation. You mentioned all the conflict points, so we need to discuss all this one because you managed to bring everything in one presentation. Thank you very much. Very nice and excellent. We will move now to the last presentation. Then we will have a group discussions and between all panelists and speakers. The last talk, it will be by our dear speakers and dear friend, Dr. Shubhadra Jalali, and she's going to talk about life-threatening event during ROP management and consequently change protocols. I think Dr. Jalali, everyone know her. She is well-known figures, a consultant ophthalmologist, director of Retina Institute, Newborn Eye Health, Eileens, and director of Quality LV Prasad Institute, also Institute Network India. Dr. Jalali, is mic with you.
Thank you so much, Professor Amri, and all my friends here, and to Novartis. and the Middle East Ophthalmic Center that is helping us to talk late in the night here, almost midnight, but I think this is very important. And I think all of you know about the hero last week, a few days back, who tried to save a life on the football field. And what I want to highlight is that the threat to life, a sudden cardiac arrest, can happen anywhere. It can happen on the football field suddenly, and of course, it can happen in our clinics. And I'm going to talk about some of the experiences that I had with threat to life in the last 20 years plus that I have been doing ROP work. So my purpose is to report some root cause analysis and what protocols we changed whenever we encountered a sudden sentinel event in the last 20 years. So this is a prospective study. We are having a prospective database of all our cases. Every case that we do in our center, it is entered in a database. And whenever there is an event, we do a complete analysis and try to find out what happened and how we can prevent it from happening again. So I'm going to talk about 8 events. And after every event, we've had a very detailed audit by internal and external experts. And whatever changes have happened, we disseminate it to all our network doctors so that everybody follows the quality protocols. So we had 5 deaths. I'll talk about 5 deaths first and then 3 cardiac arrests. So these 5 deaths, 2 occurred in the OPD while we were going to examine, but this happened before we examined the babies. 2 died few hours after laser and 1 died on the table during surgery. The first case, when the fellow doctor went to take the baby for screening from the waiting lounge, he found that the baby was not moving. The optometrist had put the drops and the baby was in the mother's lap. But when we asked the mother whether the child was moving when the drops were put, was the child moving when you came to the hospital, she had no clue. She didn't know when the child stopped breathing in her lap. And the optometrist was clueless. He said, I just put the drops. I don't know if the baby squeezed eyes when I put the drops. I didn't pay attention. And it was the fellow, when he took the baby, he found baby was not moving. So this was like, we found that when we talked to the pediatricians and neonatologists, these babies are very fragile. Sometimes they can die for various reasons. I'm not going to all those details. But what we changed was that everybody, before every step of care, each member of the team will document that there are signs of life and only then carry out the steps. So if you have to put a drop, move the child and see that the child is moving. If you're going to put a specular, move the child. If you're going to take from mother or going to give back to the mother, make sure that the child is moving and it's alive, and you demonstrate that to the family when you hand over. So the parental vigilance is also critical. So whenever we are, the patients are waiting in the waiting hall, we make sure they're wrapped well, they're feeding well, and we, tell the parents that, keep on watching the baby, as we are, waiting in the launch. So this thing was changed. Before that, we expected everybody to do it, but obviously it was not done. Now, the second case was that after stage 5 surgery in a 7-month-old baby, once we reversed the anesthesia, this baby died on table. His lungs failed to expand. There was severe abdominal distension. So what we learned was that the preterm babies can develop paralytic ileus during and after anesthesia. And you can see this, you can see the abdomen, the thin abdomen bloating, and you can see snakes around the umbilicus. So you can make out that something wrong is there. And so now we have changed the protocol, which we didn't have before, that all babies less than 2 years will have a nasogastric tube placed during the anesthesia before starting surgery. And we remove this only when we are sure that baby is breathing well and we have the tube ready in case we have to reinsert if any distension is noted. So obviously we need to keep those small sized nasogastric tubes there. And so many times I watch the baby and I find that snakes are developing around the abdomen and say please be vigilant, this baby is getting paralytic ileus. And second thing we learned that these preterm babies, they take a lot of time to metabolize the anesthetic drugs, the gases, and so they have prolonged recovery. So normally the anesthetists in more than 2 or 2.5 kg baby, they're used to giving some relaxant and they say it goes away in 40 to 50 minutes. But in these babies, it goes away after 1 hour and 30 minutes, so 1 hour and 40 minutes. So initially they used to extubate fast and then the baby would go into apnea or it would have some problem. But now we've learned this lesson. So we wait. And only when we are very sure that the baby is, completely awake and all the gases are out and they've metabolized it, that we do. We already had an SOP of having minimal drugs to these babies. Most of the lens sparing vitrectomies are very short surgeries. These are 1,000-gram babies, 1,200-gram babies, fragile babies. Very early in life, we have to do the stage 4A. We do them, but we have learned that, the anesthetists have built their own protocols and learned about how to manage these babies. And whenever we need, we have the neonatologists around us during the surgery. Because we are an isolated eye hospital, so we had to build the neonatology team in our hospital, which was a big challenge. Now, the third one was the third, fourth, and fifth, all these babies died because we think that they had some aspiration. The first one came after a long journey, and when they landed in the OPD, the mother was trying to feed the baby aspirated, and we immediately found out, and we tried to, resuscitate the baby, but the baby died after 8 hours in the neonatal intensive care unit where he was transferred. The next one also died 4 hours after laser in a government hospital. So once we had done the laser in the government hospital, the nursing staff kept the baby for 1 hour in the NICU, and they gave one feed, and then they transferred to the ward. And in the ward, the mother doesn't know, but the baby died in her bed while she was trying to feed. So again, in the hospitals now, we've made that rule that they will keep for 12 hours in the ICU after laser, because there's a lot of load of patients, there's not that much of monitoring. So in the ward, there may not be that care. And then the other one, this was brought dead to the neonatal hospital 10 hours after laser. The patient had been discharged to home, was a big baby, was fine after 4 hours of laser. But then in the night, the baby has died. We don't know what was the cause. It was sort of a cot death. So we changed the protocols that all the feeding of these tiny babies, especially those who come from far off areas to our center, should be under supervision of PULSE trained staff. We have done the pediatric advanced life support training for all our nursing staff who handle this, and all of us doctors, because previously we didn't do this, but now we have all the doctors who are handling these babies have undergone code blue training, pediatric advanced life support training. We have learned how to give gastric tube insertion, and so we are able to handle these babies better. So then 3 cases we had who we could resuscitate, and these were in my presence. So the first one was an advocate's child. I was lasering the baby, and while I was just completing the laser, the baby went into an arrest. And then successfully we could revive it because this was in the NICU. And then when we did the audit, we found that the nurse had moved this baby to another crib for the laser, and she had forgotten to switch off on the warmer. So because it was an NICU, I didn't bother because I thought that it's the nurse's duty to do that. And she somehow forgot to switch on the warmer. And so while we were lasering for 2 hours, the baby went cold and went into arrest. Now he's about 25 years old and he's a big boy. We could save him. So we decided that, the whole team will get trained. So it's not just the nurse should do it or the doctor should do it or I should not do it because I'm an ophthalmologist. So now we have that, all the handlers, we do the checklist along with the nursing staff about feeding, warmer, proper pulse oximeter, and we won't leave it to one or the other. So training and checklist about the same is now a team duty, and we do the timeout for all the cases, and also periodically we monitor what is happening. Another baby, this happened more recently. Once I finished the screening and I turned to another bed in the NICU, I just turned around and found this baby cynos. I had already handed over to the sister, and sister went to some other patient, and then we just immediately turned around and code blue was announced, and we could successfully resuscitate. This was in the ICU. Now the third one, this was something which I resuscitated this baby. Baby was in the post-op recovery, and by the pulse trained nurse, she raised an alarm that baby suddenly stopped breathing. We called the anesthetist. Actually, we have a very good video recording of this by the CCTV camera. And this was the one and only time in my life I gave a CPR. And during that CPR, which took about 3 long minutes, I was very sure this baby is going to survive. I didn't have a moment of doubt that this baby is going to die. I just gave that CPR, and this was because the drill had been done so many times in the last 10 years of accreditation that, it was just clockwork. So I think this is what we found on the football field last week, that the captain of the team, he gave the CPR right there, and we could save Erickson. So I think it's very, very important that all of us should know how to give CPR, and we should have full faith in what we are doing. and do our best. So ROP management is a very high risk situation. Even when babies are older, the deaths can occur anytime. A root cause analysis should be very ruthless. It should be detailed. It should be very honest. And we should get the external and internal experts on scientific fundamentals. We should not brush it under the carpet. We can change the protocols in areas of anesthesia, communication, handling the baby, feeding the baby, team building. And we are very happy that, all our drills and code blue training would, save the lives of these 3 babies in critical situation. So build your teams. We now have a full-fledged team in our hospital. These are all the neonatal anesthesiologists, which we have. These are all the PALS trained nurses who resuscitate and take care of the babies. And, we are going from sight to blindness if we don't care. So it's not an option for us to say that this is a high-risk baby, I will not operate, or this is a high-risk baby, I'm not going to go treatment. We are going to give the treatments, we are going to build our teams, and we are going to prevent deaths as much as possible. Thank you.
Thank you very much, Dr. Shubhadra, for a nice and excellent presentation and new things that we learned from you. Anyway, now is the time for discussions, and I think there is many questions in your mind. I will give now the mic for Dr. Hayat. We will discuss one by one. If there is a question in your mind first, yes, Dr. Hayat.
Thank you, Dr. Amri. Amazing presentation by all our speakers. I congratulate. It was a wonderful meeting. Going straight on, I would request Dr. Azad. I mean, the topic that we were discussing and I think came up very prominently, that the enemies are the VEGF, which is in the vitreous, the avascular retina, and of course, lastly, the vitreous itself. So in the case that Dr. Dogra presented specifically where there was, what is the time we have to enter in and go for a vitrectomy? That is the question. I think Dr. Dogra, or I would request anybody can take the stage, and please, I would like to know.
So nowadays, what we do for this case is we do the laser, and next day we do the surgery.
Next day.
Get the blood transfusion done. Put them on anemic. We get the
Dr. Hassan.
Next day surgery.
Do you mean that when we should intervene for the surgery? You mean?
Yes, for the vitrectomy.
Because there was already an elevated ridge. That we say.
If the child is in stage 4A and 4A, it is progressing, then we should go for a surgery in 4A and then sparing vitrectomy. Many a times, even in 4A or 4B of definitely, because 4B is already lifted. So there we have to do, and with 4A, if it is progressing, we should do the vitrectomy.
When you do the vitrectomy, do you leave the anti-VEGF? Do you inject anti-VEGF?
No. Once there is a traction, then if you give anti-VEGF, it will not be giving any benefit, So it's better to do a vitrectomy and do the laser, because the anterior retina, many of these cases, it's not lasered. So it's better to do laser when you have, do the vitrectomy. So 4A, 4B or 4B, definitely 4A if it is progressing. And there is one caveat here, that in some patients where there is a 4A or 4B, there is a lot of vascularization is there. If vascularization is there, you can give anti-VEGF, so that the vascularization is less. But majority of these cases do not have vascularization. Basically, it is the fibrotic element which is there and which you have to remove the traction. Unless you remove the traction, the retina will not fall back. And then, of course, for stage 5, definitely, you have to do the lensectomy, and then you have to do the, relieve all the tractions. And these are, of course, it is a big game. You have to choose what kind of case you want to do. And, there are certain indications are there. Yes.
Thank you, Dr. Hayat. If you allow me, we want to organize the question in a way that we will give like conclusions for these meetings. Sure. First of all, if we are having stages, and Dr. I think Azad, he explained very nicely about the weight and also about the age of, in comparison when it will be. But let's say if we are having stage, for example, 1, what is the treatment options? then stage 2, so we can have it in a points.
I actually had a specific question for the case where there were very angry vessels with Dr. Dogra showed.
I don't want to go in special cases, just we have a general information, then we can go in a details. I think Dr. Azad, if you can just give us in just a few 1 minute, a conclusion, repeat a conclusion for everyone that are hearing us. If we are having a stage 1 or stage 1A and so on, what is the possibility of treatment? I know there is some difficulties and there is some conflict here. Some people, they are treating with laser, want to give, then we can take it step by step, if you don't mind. Or Dr.
I think there are two important things are there. One is the plus disease. Plus disease is the most important thing in retinopathy of prematurity diagnosis and the management, right? If there is a plus disease, and then it depends, whether it is a normal plus disease or it is a severe plus disease, as I showed earlier. If there is a plus disease and it is, zone 1, and if it is stage 1, 2, 3, we should do the laser. If it is a severe plus, and with the severe plus, even if it is stage 1, and there is no zone 1, plus disease with zone 1, and this will be something like Aprp, we have to go for the laser. So what I want to say is the plus disease is the key finding in cases of retinopathy of prematurity. And of course, then next comes the stages. And then so this is what it is.
Okay, is there anyone who want to give a comment about what Dr. Azad? Yeah, Dr. Susanna, please.
Well, I respect very much the experience of Dr. Azad, but I didn't understand very well, because I think in Aprp and zone 1 ROP, the babies benefit from a first injection of anti-Vgf. And perhaps if you want to do laser, you wait a little bit for the vessels to grow to zone 2, and then you do laser with the minimal myopia. And of course, in zone 1, if you have already a huge amount of fibrovascular proliferation in the retina, if you make laser, you have a crunch disease. If you make anti-VEGF, you have a crunch disease, because it's a fever mixed with ROP. So in zone 1, with a huge proliferation already, with zone 1 and posterior zone 2 already with a lot of fibrovascular proliferation, with the brush border, for instance, what I think we should do is surgery. How do we prepare the surgery? If there is a very active vessels in the retina, you must do anti-VEGF, sorry. So you must do anti-VEGF, and the other day, you must be sure that you have an OR, because sometimes you don't have OR, sometimes the baby gets sick, you cannot make the surgery. So you make the anti-VEGF, and the next day you make the surgery, or 2 days later you make the surgery. For instance, in zone 2, and you have already a stage 4, sometimes I like to make laser before, because I just make the retina to stay there, and then I can easily cut the tractions. But I usually make, if I make a surgery with an active proliferation, with active vessels, I make anti-VEGF always before the surgery, because I can cut the traction and the retina goes nicely to its place, and it's an easy surgery. But if it bleeds, it's a mess. I have to go there a second time and it will detach the same. So I think in zone 1, going back, disease in zone 1, aggressive posterior ROP, and zone 2, ROP, posterior zone 2, I think there is benefit to perform anti-VEGF. And then, if you want to can do laser, if you want to can follow, of course, after that, you get in a gray area that it's not written in any of our ICROP. So there are no guidelines yet. But I don't make laser for first instance in zone 1 ROP. No, I've got Susan, minus 12, Susan, minus 18. Yes, Professor.
Yeah, no, I do agree with you. I think I missed that, in cases where there is a APROP or zone 1 ROP with severe plus disease, I think we should first inject the anti-VEGF. And anti-VEGF does work very well. You know, this is time and again it has proved. We are also doing the same thing. But for other cases, you know, as I mentioned earlier, for all other cases, I will prefer to do a laser. Even for APROP and zone 1 ROP, as Professor Mangat Dogra said, that we have to follow these babies, and I will prefer to do a laser following the anti-VEGF, because I want to be sure. I don't want to leave the child in lurch. Maybe tomorrow something may happen, and then I may be responsible for that.
Thank you, Dr.
So, I think that the same things, they agree now about the things together.
I think we should go forward. I would go forward. I would actually go
but
back.
You have a questions? Hayat, yeah, give me the
I've
question.
got another question.
Yeah, Doctor. Yeah, Susanna, go ahead.
Yes. Specifically, you had mentioned about
Hayat, can you ask? Let Dr. Susanna give her question, please.
Yes, I'm asking her the question.
No, she's asking. Please, go ahead.
Okay.
Yeah.
It's not a question. It's
a comment.
Well, I for 20 years, I do laser for 20 years. So I saved a lot of eyes, and I'm very friend of laser. I'm very friend of anti-VGF because I began to do it and loved it, but I'm still very fond of laser. My problem one is the residents don't know how to do laser properly. It's terrible. So I've got one resident that I think she will be able to persist to do a Tai Chi during 1 hour. You know, that's what we do. It's a Tai Chi during 1 hour. But the second thing is, in the older babies with anti-VGF, no recurrent disease, I have got atrophic holes, like you say, Dogra, you know? So I avoid to do laser, but sometimes I say if I would do laser, I would not have this problem. So there is a lot of things that we are still learning and still looking at. So you are completely right, because they have white without pressure at 12, 30 years old. Sometimes before they can have little atrophic holes. And I say, okay, so I've got the retina, I've got those peripheral areas that really don't work because they don't have for sure active photoreceptors. And I'm beginning to think if, yes, perhaps we should do laser because to be sure that we don't miss anything when they are growing older at 18 and 19, perhaps we can have late retinal detachments if we don't follow up those kids. And those kids now will be adolescent, and the adolescent
Dr. Susanna, how long do you follow the patients?
Now it's for life. My oldest patient is now 15 years old.
No, I mean, what is the policy? I mean, how do you, is there a guidelines for you to follow the patients?
It depends on, but usually make the injection, then I see each week to the first month. Then it depends if there is any kind of, if the vessels grow nicely to the periphery, I just see the baby 1 month, but I see monthly. Even if they are peripherally and they are quite good, I see them monthly until 1 year. And then each 3 months, the next one, and then each 6 months, and I see yearly a baby, a girl that now she's 15 years old. So
you mean you are continuing seeing the patient even after the age of 15 years? You know, when we can stop seeing the patient?
We cannot stop seeing the baby. I've got patients with 40 years old that was treated by other colleagues.
But he is now not an ROB. This is an adult problem again.
It's an adult problem, but they have how can I say, interface problems? I mean, epiretinal membranes and retinal detachments.
So, Dr. Hayat, I want your
Susanna.
Thank you very much.
Yes.
Thank
Dr. Fahad, you have a question? Yeah, go ahead, please.
Yeah, no, just from a medical retina perspective. So I don't treat any ROP, but obviously, as people realize, in proliferative diabetic retinopathy, we do have anti-VEGF, and unlike ROP, we have to give 14, 15 injections over a 2-year period. And what we found is it doesn't give any long-term regression. So we haven't really abandoned our retinal laser. In terms of ROP, do you think there would be any role after you've given anti-VEGF, possibly to do a fluorescein angiogram to see if there's any persistence of retinal non-perfusion, and maybe consider a combination approach for most of your children in order to avoid regression or recurrence of disease.
That's what we do. So everybody now is treating with anti-VEGF if they have a vascular retinas at 60 weeks post-menstrual age. Everybody does an angiogram to see what kind of avascular areas we do have, if it is a quiet one with no fluorescein leakage or not. So I think everybody does that, don't we?
I have one question, Susanna, here. Of course, it's an excellent tool if you have FFA. But
yes,
if
it's
you
the
can
one who
add
has
on,
the...
even genetic testing, if we can add, like some of the now genetic markers now, if you can have full gene sequencing in addition to it, you can actually know which are the ones you can laser even earlier. And it will cause a less of our follow-ups, because now we have a couple of genes, especially when you talk about fever and so on.
Yes, but even if you don't have the gene of fever, you can have fever, because you can have fever 50% without positive gene, just family history.
That's why
so it would be a great help. Of course, it would be a great help.
Do you have fluorescein here? Do you have a fluorescein?
Professor Dogre,
you are having fluorescein for the baby?
Yes,
ROP?
Fluorescence, yes, of course. Specifically with the new machine, of course, if they have the older model of red cams, that is not possible. But the new ones, yes, you have available.
No.
I'm saying available with you.
First,
Dubai hospital,
cam which was there, they had the fluorescein angiography.
Yes. The second one didn't have the what do you call it?
Second one didn't have. Correct.
Shuttle.
Yeah, I correct myself. Yeah.
Okay. I think Dr. Hassan have question. Dr. Hassan, yes.
Yes, about just I want to mention about the treatment, because when you enter the NICUs and treat these babies, and you choose to use this modality of treatment, you should have a system. You should first, if you need the injection, if you have the RedCam with RedCam 3 with fluorescent, then you can follow up these babies. About the treatment, about that, after that the baby discharge and you follow up in the clinics, you can see this peripheral. If you can take image by Optos, by RedCam, you can do that. But if you suspect that there is recurrence, you take this patient for OR and you can do the laser for that. But if there is no activity, you can see the periphery for the patient. I think this is debate, because sometimes somebody said after 55 weeks you should do the laser. Somebody is 65 weeks. Somebody can't tolerate it. For us, we can't tolerate it even for 70. As we can examine this baby and he's stable, full dilated, there is no kind of recurrence, no blus, we can see the retina stable. Taking this baby for the OR for us was a problem. If the parents they refuse the examination, or the baby we can't examine this baby in the clinic, then we take him for OR and examination under GA, and we can do, if there is a valuable of RedCam, do FFA, or we can do the laser for a vascular area. It's about using the injection. You should follow up these babies. If you don't, you should follow up these babies in the first maybe 12 weeks or 16 weeks, every 2 weeks, because there is the kind of recurrence there. And after that, if you can see the stable, you can maybe extend it for 1 month, 2 months, because you can see the peripheries. There is kind of granularity for the periphery, the kind of regression there. The vessel is advancing, but if you feel this vessel is already stopped there and you are suspecting some MVE, the choice for the laser is safer for the babies. And about the question is about, I don't know about the typical kind of ROB, where the fibrosis is there and you are afraid from crunch. I think there is no one can give you a clear cut about that. Somebody's do some laser as Dr. Dorga did, and vitrectomy second day. Somebody did the injection as Dr. Susanna did. Somebody's go and do vitrectomy and give injection inside the most important thing, that this kind of disease is a surgical one, not just the laser. They need anti-VGF or laser for him. A typical kind of ROB, which, as mentioned, that it's a mix between fever and ROB.
I need to hear Dr. Mangata. He didn't.
I have one
question.
I have for Dr. Hassan one question.
One question.
Just I will go back. Dr. Hassan, just to continue, I have to ask you, when you're giving the injection, Where are we injecting? That's the question I would like to ask. Is it 1 millimeter? And what is the size of the needle as we look at the new guidelines? Please, if you can just.
I will speak about which we use it in Dubai Hospital. We use 1 millimeter from the limbus. We use the caliber, and we use the 30 needle, and we go around peripendical to the tilting to the back as an kind of away from the lens. And for me, I prefer to hold the injection. Somebody injected for me, then I will be stable, because these people under topical. I prefer to use it from temporal area, not from the nasal area or from superior. Generally, and I consider it as 2 procedures. We inject the right eye alone, then we re-scarb again and drape the other eye, and we inject it again. And
why I asked Dr. Hassan was that now there is shorter needles and 32 gauge needles. How many of the panelists would like to comment on that, please? Is anybody using the 32 gauges?
I'm not, I don't have, but I'd like very much to use it. If I had it, I use it.
There is suggestion for Novartis already mentioned that we wanted from, we suggested that to have a preloaded Lucentis for babies, and with fixed, as we use it in the flu injection for the vaccination, it will be embedded the injection in the syringe.
That would be something good.
That would be very great.
I will advise them that it will be around 3 millimeters, 30 gauge needle or 32 with the hinge, which give you the distance from the limbus. And we hope that this idea will find a way for them. It will be better for us, for everyone. Especially,
can we have also reduced cost to the parents, because now they are paying for adult dose and we are giving only pediatric dose. So I have told the they give me pediatric dose, I'm not going to inject randomized.
Dr. Jalali, which we do it now, sometimes we throw the half of the injection, or we use the insulin syringe to adjust the dose. And I think through the studies, they use a micro syringe, which is not available in our hand. So we hope that, because I feel now with the new studies, if you see, they use the 0.1, they use, Dr. 30 microgram from Avastin. How you can adjust this in a syringe? You need a specific syringe with specific needles. We hope that this is, I think,
Dr. Hassan, we are running behind the time, so we need
Dr. Dogra,
if there is, can you, please, 1 minute.
I just wanted to ask one question to Suzanne. My concern with anti-VEGF, which I think you have now long-term follow-up, at least in my experience treating fever over a period of time, they suddenly worsen during puberty. All fever, they go haywire. That is where we see the problems. So if you have seen fevers over a period of time, most of them, when they suddenly go to puberty, they'll either exudate or they'll suddenly progress. So would we expect something like that with anti-VEGF peripheral retina? Same kind of thing happening. So this is something, a big concern I always have. Since you have a long-term follow-up, I thought maybe you'll have some light to.
Yes, I think we have this problem. I have two childs, one 10 years old now that has atrophic holes in the periphery, and I had to do laser, and another one with a huge lattice at 9 years old. So those are the ones that I injected, but had no recurrent disease. But I followed them. Suddenly, I began to see white without pressure. And then next year, a hole in the retina. So I said, okay, so now I've got more problems to follow these guys. So yes. Now what I'm doing, I'm following these patients. But if this is a risk, perhaps we should consider lasering all those vascular areas, because it's easy. Sometimes we don't have a general anesthesia because it's not such a wide area, but perhaps you can avoid, of course, we laser too much for sure, but perhaps we'll avoid this kind of problems that I was not expecting to have. We are focused on the relapse disease, and suddenly we have interface problems, not the recurrent disease. So we have really a lot to learn about this disease, a lot.
Thank you, Dr. Susanna. We have...
Dr. Emery, just one small thing which Susanna also pointed out, which I think requires us to study more, is the choroidal problems. We reported choroidal ruptures, and from Thailand it was reported. And when I talk about choroidal problems, many experts, they refuse to publish, they refuse to accept. But I think with the angiogram, we will get more information, maybe with enhanced depth imaging, OCTs, maybe ICG in future. I think there's something we have to look out for. There is choroidal effects, both of prematurity and of anti-VEGF. I think these require to be studied further.
Agree with you.
Thank you very much. I think we are having few comments and few questions from participants. There is one comment from Dr. Rituraj. He said, increased pupillary dilatation is one more sign of ROP regression post anti-VGF injection. This is a comment to Dr. Azad. If Dr. Azad wants to comment about this.
I do agree with him. Sometimes, when the pupil is not dilating and you're starting the laser, while you have done the laser, in between you find that the pupil is dilating. So it's, pupillary, and as such, if pupillary dilatation is a good sign. If you find that the pupil is dilated, this means the laser, this means the ROP is not very severe. This is another, indication. So I think pupillary dilatation is definitely a good sign as far as retinopathy of prematurity is concerned.
Thank you, Dr. Azad. There is another question for Dr. Susanna. In infants with posterior avascular periphery after anti-VGF and FA shows no activity, do you repeat the FA as follow-up for such infant? And if yes, how frequent? I think these are very important questions.
Yes. If I see there is no leakage in the periphery, usually I do this at 8 months of year. So I've got the avascular area. So I perform the first angiography. Depending on what I see, usually I follow up. How do I follow up? Each 3 months I see the baby. If there is no sign of anything, I do the angiography, fluorescein angiography, just 1 year later. So I sedate the baby or the child and make the fluorescein angiography. And if there is any problem in between during my observations each 3 months, then I perform again the angiography, but yearly, because it's an invasive procedure, and less than yearly if I find something that there is, I'm aware during the 3 months observations, even with the retina, calmly retina, cold retina, as I used to say, because we are in a new field. We don't know anything about this. So we are making the way, we are making the discovery of all this. So that's the exciting on all this.
Thank you.
That's why we should all take change information, even if we cannot publish, or we have not the time to publish, because I work a lot, so I cannot publish, but we should anyhow between us change this kind of information. It's very, very important.
Yeah, I agree.
I
Thank you very
question,
much.
Dr. Amri, for our...
We have 3, okay. Yeah. To whom?
Just a quick question. Anybody can answer. Dr. Hassan had mentioned about the biphases, 2 phases, angiogenic phases. So what would be the demarcation when we're looking at oxygen saturation? Are we looking at, because we have our neonatologists working with us, is it 33 weeks that would be cut out, that when we change our strategy in terms of, or whether it be specific for every patient, how the retinal findings are, that we would like to change our oxygen saturation from, let's say, 88 to 92, we increase it in the second phase to more than 96? That's the question.
I can ask Dr. Dogra to comment about this one, please.
I think we have a lot of studies as far as this part is concerned. And these days, most of the time, at most places, they would like to keep it somewhere around, maybe around, say, on an average 92 or something like that. And it has been seen. The problem is fluctuation, you see, the fluctuations. If the fluctuations are there, then it is very dangerous. So you need to avoid those fluctuations. If you can keep it at that level, that is what most of the time our neonatologists, in fact, I belong to a hospital, which is one of the largest neonatal center in the country. So they are very particular about that part. And if you have fluctuations, that means the ROP is going to progress. But if you keep it in that level, then you are not going to have either also systemic issues like the lung issues and others, which may happen if you I make it too low or too high, which was seen also as we had the various trials which were done by the neonatologists that we are all aware of. So I think that is fluctuations would be my take on this. Yes.
Is there any other one?
Can I mention something?
Yeah.
About this question, this is a very important thing, because we said that this is because the prevention of this disease is from this step, Dr. Hayat. And thank you for that, mention this. This about the phases, the difference between the NICUs around the world, according how they use the oxygenation and how they maintain it for the stop ROB, which already they did these studies. And the oxygenation should be in the lower side, which can save the brain and can save the eye. And maybe this is difference between, I said, according to the level of the NICU service. But which, as Dr. Dorga mentioned, the fluctuations, because this is relative to the human being. But now, these days, there is kind of ventilation, adjust the oxygen, monitor the oxygenation for the babies all the time, 24 hours. This is, as they implemented this kind of implementation, the ROB incidence will be less than this. Yeah. Because before they depending on the staff to adjust the oxygenation. So sometimes maybe somebody's missed this concentration or observation. So depending, this fluctuation happen. But if the machine adjusts this concentration, it will be lower and best.
Also very important is the management of anemia and the lungs, nebulization, lung physiotherapy, anemia. Anemia is so important. When people laser and they write to me, baby is not responding. I said, did you look at the hemoglobin? You give transfusion, the laser works much better. Same way with anti-Vgf.
Thank you. Weight, the weight is a very important thing. If there's no weight gain, I have seen they perform very badly.
Okay, we have just 3 questions we need to finalize, because you're already, I think, too late for our guests from India. I think they are over midnight, so I don't want to delay more. So there is a question, I think this one from Dr. Hazim Khalaf. He is asking about, he is having a confusion actually. He's saying that some confusion. When we said zone 1, do we mean revascularization in zone 1? So he wants to clarify the meaning of zone 1, zone 2, zone 3.
Oh, zone 1.
I think someone is answered the question. I thought write something. Yeah.
No, it's just a live answer. Go ahead, please.
Go ahead, please. Yes, Dr. Azad, we are hearing you.
Yes, zone 1 means, you take the center of the disc and from the macula and draw a circle. All area falling within is the zone 1. And in zone 1, the vessels are growing from the optic disc and going on to the ora serrata. So there are different, stations are there. From disc, it has gone to the, the zone 1. And from the zone 1, it has gone to zone 2. Zone 2 is an area from the optic disc to the nasal ora serrata, and then taking an arc and, drawing a circle. That is zone 2. And anything beyond that is zone 3. So these zones are basically to give the prognosis. If something is happening in zone 1, it is very bad. If something is happening in zone 2, it is not bad, not good. But if something has gone beyond zone 2 and gone to zone 3, this means that this ROP is now regressing, or it is, not very malignant, or it is not going to harm you. That is the concept of the zone.
So one caveat is there, which is given in the IT crop classification also, that because the ROP happens in a wavy fashion, so you could have some ROP which is in zone 2 and some in 1. So the posterior most zone has to be taken. So even if a small part of the disease is still in zone 1, that is zone 1, and the rest is in zone 2, you still call it zone 1 disease. So this is given in the classification also. The posterior most part has to be taken into account, not the anterior most part.
Okay, thank you very much for this clarification. This is a question to Dr. Susanna. Do you modulate the dose of the fluorescein in babies with poor renal parameters? Or Susanna?
Well, specifically, we usually use 0.1 milligram per kilo. So never had this kind of problem, because usually
and also he's mentioned cardiopathy.
They have so many problems, so I presume that they have problems from everything. So I use the lowest dose, that is 0.1 per kilo with a flush. In the beginning, I used diluted because I thought it was better, but no, you give the basic dose and then make a flush. It's the better.
The basic question is, if there is a renal dysfunction, and if you are injecting the fluorescein dye, is it going to do any harm to the baby?
I don't know. I think not. Perhaps they will stay a long time with the angiography.
I'll tell you something. It's not. If you do it in the adult, nothing happens. Only thing is that the excretion is delayed. If it is excreted, almost 100% of the dye is excreted within a period of, say, 24 hours. But if somebody has a renal impairment,
it may be prolonged.
Yeah, it may be prolonged for a long
take
time.
more time.
But fluorescein does not cause, in the dose which we give.
No, any harm.
Yes. It may cause discoloration, or maybe sometimes, some allergic reactions and all that, but not otherwise.
Yes.
Thank you very much for this, for answering the all question. We have only, if there is any comment, Dr. Fahad, if you have any question or comment, if you are still with us, Fahad.
I am. No, yeah. I'm just very fascinated by the general kind of discussion as a medical retina specialist. I think the only thing that wasn't clear to me is what would you do if you didn't have a fluorescein angiogram? So you give your anti-VEGF, you monitor for clinical signs of regression. I think you need to combine, even though I'm not an ROP specialist, I still think laser is the only thing that gives you the kind of the long-term regression and protects and really modulates that disease. What do departments do if they don't have fluorescein angiography?
I want to say to all the audience that fluorescein angiography is not routinely indicated, because fluorescein angiography is not available everywhere. Fluorescein angiography is only indicated for a selected group of babies. It is good for teaching, it is good for research, it is good for the academics, but not for the clinical purposes.
Can you ask this? Can we have the comment from Dr. Susanna, because she is the one present, so I want her opinion.
Well, I think who has the fluorescein angiography is lucky one, because can on time know and rely what's happening in that retina. If you don't have, you can do two things, or you follow for life, for each 6 months, each year,
I'm not
or
saying,
then you make like most of people, laser of the periphery and rely and hope that everything goes okay. But even I show you that leakage, even with laser, in those vessels are still there.
I'm not saying that it is not at all required. It is required for very selected group of babies. You cannot do for each and every baby fluorescein angiography. For many reasons.
Do you think?
Just 1 minute, Dr. Amri, I want to make a comment.
Yeah, can you have someone in between? Not Azad, not Susanna. Okay.
I don't have FFA, but I wish I had it. I had it in the old machine that has come.
Can I add one?
Can you ask Dr. Susanna? Can we have Dr. Shubhadra to finish, please?
Yeah,
please
the
go ahead.
question asked is that if we don't have FFA, ideally we should have FFA and we should do it in all Avastin babies or all anti-VEGF babies. I agree with Susanna. But if you don't have, then the system is that there are very good publications of people having drawn the cartoons of the vessels. What happens to these vessels? There's very good publications of Tapas Padi from our group. So you need to then follow those vessels and learn the difficult way, which vessels are the dangerous vessels, which are the circumferential vessels, which are the tungsten vessels. So we can learn till we get the FFA. But I think the idea is that yes, we need advanced technology, we need FFA, but short of that, we have to learn the difficult way, which is also possible. So please go
It's
through
not
those.
difficult.
Yes.
Not
I
difficult.
have
You have
one
to see
comment.
the
Okay,
Simple way. Simple way.
we will not finish. I know it will be a debate
Yeah.
about
Dr.
this one. We
Amri,
will not
Let
finish.
time.
one comment.
sorry,
This
Muhammad.
was the earliest
Yes,
question.
yes.
I will
Can
just
we have?
make one comment. That was Dr. Amri, you initially asked, sometimes we don't have a red cam. An alternative to that, we can also use
Drawing.
Optus machine, Optus. If a lot
It's
of us
wonderful.
colleagues have Optus,
iPhone.
and you get spectacular pictures if you can have the baby in a
Yes, in
aeroplane
flying position.
in the flying
Even
position.
iPhone.
And
Even iPhone.
even
It's a
iPhone, yes.
non-touch, and it's a non-touch. It's a
I
non-touch
would
way, so
specifically
it's
say
very
you
nice.
can detach the gadgets, which is for the chin, and then you can put the baby. Dr. Hassan, of
Yeah.
course, he's there, and we do it quite regularly. Sometimes it's not available, sometimes it's not working. So you can always, just a small comment, like
Yeah, we have prepared a bit.
I think we will have a lot of things about ROP. It will not finish with one session. Just we are highlight about certain points, and there is a lot of debate, and I know. But I would like, from while we are here now, if you allow me and if you accept, we are going to have a conference on 23 to 25 of September. It will be a MEOM third sessions or edition, and we would like also to have all of you also, and one also ROP, also in other also I mean VR, and the other one surgical retina. But I know you are an eminent in this field, so we can learn again. But we will organize it in a certain way, just to the direct to the points which are difficult, and there is a debate, and we agree on a certain point that can. And I have one comment about the I mean the FFA. Every time we are getting something new, so we have to learn from this one, and we have to get it. Before, we don't have, for example, OCT, and we are depending on the macular edema treating in some way. But when we have it, it'll give us a lot of more. And I think everyone is agreed. Azad is not against this one, but he is saying it is about certain things that should be. And Susanna, she is saying she's using a lot, and it is good for all. So thank you very much for all your information, for your expert, for your time, and for this excellent and discussions and presentation. Thanks for Dr. Azad, Professor Azad. It's our pleasure to have you with us. Dr. Dogra, Dr. Susanna, Dr. Subhadra, Dr. Hassan, and Dr. Hayat, my friends, and also from UK, my dear friends, Dr. Fahad. I know he was telling me he will not be able because he is main interest in retina, but he have done a good job. Thank you for all of you. Thanks for all participants. Also, before I want to say that for all participants, they can get their certificate.
Great.
And the link is now available on the chat. Just go there before you close. And thank you for all, and good night. Thanks a lot. Bye bye.
Thank you.
Thank you very much. Thank you. Bye bye.
thank you very much.